Hey guys, am I audible and visible? Hello, bad doctor. Good evening. Should be good doctor, right? Am I audible and visible? Okay. So let's start a quick revision on Neoplasia chapter. Right, I hope the exams must be around the corner. Your prelims must have been going on as well, right? So, guys, if you're online, can you just let me know when your exams are? Good evening, Devangan. I'll have only two sessions of general pathology. One is this. The next session is tomorrow, which is on immunology and genetics. We had a quick discussion about general, the first inflammation chapter and the cell injury in the groups, right? Previously, I'll try to find some time in between, and I'll try to make sure we'll complete little bit of things what you asked, like bleeding disorders and others. Fine. Okay. All the best, Rishikesh. You will do amazingly well, right? Best wishes and prayers for you. Fine. Okay. So let's start about neoplasia. So we won't waste any of your time. We'll just quickly go through what are the points is required to be written. If there's any question with respect to neoplasia, and a few questions have been repeatedly asked. One long answer which can come in your exams with respect to neoplasia is like molecular hallmarks of cancer. The 8 different molecular hallmarks. How to compress them and write in like 3-4 pages is what we'll be seeing. One, and the second, there are few important 5-mark questions, like metastasis can be easily be a 5-mark question. Paraneoplastic syndrome can easily be a 5-mark question, right? So carcinogens, especially the oncogenic viruses, can easily be a 5-mark question. We'll have a look at them as well. Fine. Okay. Thank you, Sam. Hope you're enjoying it. Fine. So let's go to metastasis. So any 5-mark question, like I told previously, if it's a systemic pathology, we went with a template, right? Unfortunately, general pathology, I cannot go with a template because systemic path, it's about etiology, pathogenesis, clinical feature, way to diagnose, confirmation, because they are diseases. General path are not diseases. Primarily, general pathology are nothing but some basic concepts which we have been applying in systemic pathology. So for general pathology alone, I cannot go with the template. We have to create templates for each and everything. I am sure you will know most of the questions which have been asked in general path. For every general path question, be it a 5-mark or a 10-mark, think for a minute. Think what all you know. If it's metastasis, one, I'll write the definition. Second, the root of spreads. Third, if you want the steps of metastasis, what you read in your hallmarks of cancer, right? And what are the routes of spread? I can have hematogenous, I can have lymphatic, I can have the seeding of body cavities, pseudomyxoma peritoni, and the special type of metastasis like drop metastasis, right? So for every general pathology question answer, I want you to think for a minute. Think whatever you have read regarding that question, be it in micro, farm, patho, doesn't matter, and then give a beautiful structure for it. Fine. Okay. So Mets, the definition Robbins, it's defined as a spread of a tumor to sites that are physically discontinuous with a primary tumor, right? So primary tumor can be in the skin. So from skin to axillary lymph node, they are physically disconnected, right? So, but when I say I have a tumor here, it's going to this area, from this to this area, it's physically connected, right? So that I got a spread of a tumor. If it's from the small intestine slowly growing through the large intestine, it's physically connected. Only when it's physically disconnected, I call the term, we use the term metastasis. Fine. So I'm sure that you must have known the roots of metastasis. One is the lymphatic route, undoubtedly is the most common route of metastasis. Okay, can anyone tell me which tumors prefer lymphatics, carcinomas or sarcomas? You know the answer, right? Let's keep on answering. I'll ask you questions, keep on typing. So it's like a revision for you. Carcinomas prefer lymphatics. By default, carcinomas obviously going to prefer lymphatic tissues, right? So this is not enough for me for with respect to lymphatics. Let me kind of put a little bit of clinical correlation also here, right? So when I meant clinical correlation with respect to lymphatics, I am sure in your surgery postings and also when we read about breast cancer, we must have read about sentinel lymph node. Put a word about that, right? So we'll write what is the sentinel lymph node. So put a different color if you want. Okay, we have sentinel lymph node. Sentinel lymph node, can you guys again say what does it mean? It's the first lymph node that drains the cancer or drains the tumor site. Whatever may be the tumor, if it drains the tumor site, that's the first lymph node, right? The practical application for that application is very simple. If sentinel lymph node is involved, then I have to take care of the lymphatic spread. If the sentinel lymph node is not involved, I need not take care of the lymphatic spread, right? It has a practical implication. So intraoperative diagnosis of sentinel lymph node involvement will help in managing the patient, right? Will obviously alter the management. If you have enough time to explain what is the management, give an example of breast cancer. If sentinel node, axillary node is involved, I will do an radical mastectomy along with lymph node dissection. If axial lymph node is not involved, I'll just remove the breast cancer and the tumor alone. We will not touch the lymph node, right? So give an application if it's required and if you have adequate time. Otherwise, just mention what's a central lymph node. It's implied. If you know this, I'm sure that you know the application also, right? Then go to hematogenous. Okay. So hematogenous, which is preferred? Sarcomas prefer hematogenous route, right? So any fleshy tumors, sarc is muscle, right? Any fleshy tumor prefer hematogenous route. So I don't have much to write about this, right? So there are two organs. The organs which have maximum blood supply definitely are preferred by hematogenous route. Lung and the liver are the common sites which you will get metastasis from any different organ to the body. It goes and gets deposited in lung or liver because of the abundant blood supply, right? At the same time, there are few exceptions. Exceptions again gain more marks because you know that common dictum and also you know something away from that. Few tumors or few sarcomas which prefer lymphatic spread. There are few tumors, definitely few sarcomas which prefer lymphatics or lymphatic spread. So can anyone tell me any sarcomas which comes in? Hello Salam, all the very best for your exams. Hopefully you'll do amazing. Best wishes and prayers for you. Good evening Samantha. Okay. So any sarcomas which will prefer lymphatics? Anyone? There are lots of sarcomas which prefer lymphatics. Quite a few of them. I'm sure you must have known. Okay, we have clear cell sarcoma. That's one of them which prefer lymphatics. We have angiosarcoma which prefer lymphatics. Fine. To name a few, right? So there's a mnemonic called a scream or scare, right? We have your rhabdomyosarcomas, angiosarcomas, clear cell sarcomas, synovial sarcomas, right? And epithelioid sarcomas. All of them prefer lymphatics. Just write a couple of them. That should be more than enough. Just to know that you have a knowledge of something will go out of the ordinary, right? Then seeding of body cavities. Seeding of body cavities, it's also called as a direct spread. So it's a direct spread from your lungs into the pleural space or from your intraperitoneal organs, right? Good evening. I'm not able to read your name. Nirmaya something. Okay, sorry. Okay, from an intraperitoneal organs into your peritoneal cavity or the ascitic fluid, right? So when this happens, when there's a spread from the intraperitoneal cavity to an ascitic fluid or lung from pleural fluid, it's mandatory, good evening Sarkar, to tell that you will have an involvement of the peritoneum in case of an colonic, in case of an ovarian malignancy. Good evening Rahul, right? So that's your pseudomyxoma peritoniae. Pseudomyxoma peritoniae is a very classical example of a terminal illness of your ovarian, of your colonic, sometimes even appendiceal malignancies, right? So all these tumors can be mucin secreting and the entire mucus will go into the entire abdominal cavity, which is a stage 4 cancer called a pseudomyxoma peritoniae, which has a very, very poor outcome. That also comes into seeding of body cavities, right? Again, a word about rare metastasis. When I say rare metastasis, there's different types. It's not the routine. Drop metastasis, any lesion from the cerebellum, okay, a cerebellar tumor, example medulloblastomas, can definitely drop from the cerebellum and can spread along the spinal column, right? That's one. Okay. Then I can have intravenous growth. Can anyone tell me which are the tumors which can grow into the vein? Not spread via vein. Spreading via vein will go into hematogenous, right? If it grows into the vein, again, it's a very rare thing and a unique phenomenon. You must have definitely heard about your HCC and RCC. Hepatocellular carcinoma and renal cell carcinoma can easily grow into the inferior vena cava from the renal vein and even can reach till the heart. Same with HCC, it can go into the hepatic vein, IVC can reach till the heart, right? These are very unique things. If you want to add one more, we have one more thing called Krukenberg's metastatic tumor. Which organ? Krukenberg is not exactly unique, but a little bit. We have something called retrograde lymphatic spread in Krukenberg. So because of the retrograde lymphatic spread, you will have bilateral ovarian metastasis. It goes to ovarian metastasis classical, which is also important thing, fine. Yes, they do follow hematogenous. This is intravenous growth, Samantha. It's a very rare form of metastasis. See, almost every cancer can go into hematogenous. Carcinomas prefer lymphatics. Doesn't mean that it will not go into hematogenous. Squamous cell carcinoma can go into lung. Your renal cell carcinoma can go into bone. So obviously it's hematogenous. These two things can grow into the vein, right? Just 2 slides. That should be more than enough for you to write about 5 marks for a metastasis. If you want to add these steps of metastasis, we'll be seeing them along with the hallmarks of malignancy. Fine. Okay. Perfect. Now let's go to the molecular hallmarks. Generally, if I'm going to ask the molecular hallmarks, I'll ask them as a long answer, right? Yes, Rahul, you can go. We'll give a random cancer and say describe all the classical molecular hallmarks of malignancy. If only one of them is asked, please explain them in detail. If everything is asked for a 10 mark, it doesn't make sense for you to explain each and every gene in detail, right? Just talk what is about proto-oncogene, few words about that, and few examples. That's all. Few the words about tumor suppressor gene. Remember, you should definitely mention the Knutson's 2A hypothesis and go with the tumors. Few examples. Few things about Warburg's. Few things about angiogenesis. Fine. Then that's a root of metastasis. That's what I'm saying, right? We'll look at that, Samantha. Very soon we'll look at metastatic cascade, right? The steps of metastasis. So what do I mean by the root is, I think we have read this long back. We have the vein here. We have the IVs here. That's how the tumor goes, right? So from here, it can grow like this. That's what I mean by intravenous growth. Not breaking and spreading. It can grow into the vein. Fine. I'll just erase this. Okay. Now, let's talk about every individual hallmark, what to write, and few things which you want to remember. And this you must have definitely see we have completed pathology. So now these are not aliens. We already know about them. You definitely know at least more than one tumor for everything, right? Good evening, Meher. So self-sufficiency of growth signals, that's your oncogenes. So here the first is proto-oncogenes. Write what is a proto-oncogene mean? They are normal genes necessary for cell division or cell growth. Okay, they're normal genes, they are not a problem at all. So oncogene is a mutated proto-oncogene. So gain of function, loss of function. Okay, so oncogene, it's nothing but a mutated proto-oncogene, and it's undoubtedly a gain of function mutation. I'll discuss later, Samantha, just let me know. Okay, it's a gain of function mutation. Because of gain of function mutation, it could be an amplification. You can write that more. It could be an amplification. Can it be a translocation? BCR ABL. Yes, it could be a translocation, or it could be just a mutation. Amplification is HER2/neu. Which tumor will get amplified in HER2/neu? Breast cancer, right? It can be an amplification. It can be a translocation. Because of this, there's more and more cell division. So it results in the cancer or results in the tumor. So the reason why we want to create this illusion is, I know what is a normal proto-oncogene means. I know how an oncogene will act. It could be any of these things. Ultimately, it's going to increase cell division and it's going to cause cancer, right? Now, few of the oncogenes or proto-oncogenes, which is essential. EGFR. Okay. Shreyas, let's complete first here. Then let's go and have a look at this. Fine. Okay. Yes, it's gain of function, Samantha. That's it. Fine. Okay. So EGFR receptor family. So what happens in EGFR receptor families? There are two things. So we have ERBB1 and then ERBB2. Okay. So two of them are there. ERBB1 and B2. ERBB1 is your EGFR receptor and ERBB2 is your HER2/neu. Can anyone tell me where did we read about EGFR receptor? EGFR is mutated in lung adenocarcinoma, right? So obviously I'll just write lung adenocarcinoma. Here you need not go and fill everything we know about it. At least one tumor is more than enough. HER2/neu, you will never forget it, right? HER2/neu undoubtedly is seen in breast cancer. Okay, it's seen in breast cancer, HER2/neu, and ERBB1 and EGFR is seen in lung adenocarcinomas. Fine. ALK is anaplastic lymphoma kinase. We did a rare lymphoma called an anaplastic large cell lymphoma, and this also is seen in lung adenocarcinomas. Just write the terms, just write the tumors if it's just a part of an essay question. If this alone is asked in a 5-mark question, maybe a little bit elaborate on it. Fine. KRAS. KRAS can be seen in colonic tumors. KRAS can be seen in your lung adenocarcinomas. KRAS can be seen in your pancreatic adenocarcinomas. All the adenocarcinomas, we have the mutations. Fine. Meryl, I'm not understanding your question. Please, can you rephrase it? ABL. Can anyone tell me where do we see BCR ABL translocation? So instead of just writing ABL, write BCR ABL. Though ABL is the proto-oncogene or oncogene here, you will definitely never forget that, right? CML. Again, like I said, just CML is enough here. If it's a part of a long answer, if it's a part of a short answer, you can easily write at least few words about CML. Because of this translocation, we have the fusion product, more activated tyrosine kinase, so that results in the cancer formation. Fine. Okay. JAK2 is seen in polycythemia vera. and also in myelofibrosis, and also sometimes in essential thrombocythemia, right? At least don't forget polycythemia rubra. ALCL is anaplastic large cell lymphoma samantha, fine? c-KIT. I'm 100% sure you know at least one tumor with c-KIT. Any tumor which comes to your mind? There's a tumor which happens in the intestine, which grows outside the intestine and not into the intestine, which comes from interstitial cells of Kayal. What is the tumor? GIST. That's one. Second, there's one more tumor which happens in both testis and ovary, where you have nesting pattern, and in the septa you have lots of lymphocytes and clear cells. What is that? Dysgerminoma seminomas, right? Okay. So dysgerminoma seminoma can have c-KIT. Your GIST can have c-KIT. There are many more tumors which can have c-KIT, but these are just little bit examples which you have already read in systemic pathology, right? So this is just a compilation. If you know more proto-oncogenes, I'm 100% you know more proto-oncogenes, add them to it. But at least write 3 or 4 as examples. As a part of an essay question, it looks good when you write 3 or 4 as an examples. It's very simple to remember tumor suppressor genes. Proto-oncogenes might be sometimes a bit more tricky, right? That's the first molecular hallmark. Let's go second. Second molecular hallmark is insensitive to growth inhibitory signals, which are nothing but tumor suppressor genes. Again, the normal function, as the name says, it will reduce cell division. So for us to have a mutation, so in other words, a mutated tumor suppressor gene, TSG is an abbreviation. Whenever you are using abbreviation, please write in the first letter, like I'm describing tumor suppressor the first time, write in brackets TSG. Then you can use TSG as short form wherever you go, fine. Mutated tumor suppressor gene, gain of function, loss of function. Obviously loss of function mutation, or it could be in deletion, right? So now it makes much more sense for me to write Knutson's two-hit hypothesis. That's important. Knutson's two-hit hypothesis will be true for every tumor suppressor gene, though we read that in only we discovered them in your retinoblastoma. It's true for every tumor suppressor gene. It says that only biallelic mutation will cause both the alleles will have loss of function mutation. Only then there will be increased proliferation. Only then you will have a tumor. With one mutation, you cannot have a tumor. I need 2 mutations to have a tumor. Tumor the gene heading will not end without writing about Knutson's two-hit hypothesis, right? Few words there. It's very easy to remember the genes involved in tumor suppressor genes. Either remember all the cancer syndromes. Just colon cancer is enough for me. Everything in colon cancer, FAP, APC is tumor suppressor gene, right? HNPC, tumor suppressor gene. Peutz sugar, tumor suppressor gene. P10 hematomata syndrome, tumor suppressor gene. You will not forget retinoblastoma and P53, right? And VHL, we have a history about it, right? So we have lots of them we already know. Retinoblastoma, undoubtedly a tumor suppressor gene. So there will be an increased risk of retinoblastoma. And what's the bone tumor you'll have risk? This was there in one of your students' long answer. Retinoblastoma always increase the risk of osteosarcomas as well. Okay, so retinoblastoma and osteosarcoma, it always is coexistent, especially in a congenital person, right? Great Lakshana. P53, it's, if you want, right, add that retinoblastoma is the governor of cell proliferation. P53 is the guardian angel of the genome. Everything if required, right? Otherwise, right, just there's an increased risk of leukemia, breast cancer, CNS, and soft tissue. This combination is very specific for a P53 mutation, which we called an Li-Fraumeni syndrome. The answer should be based on the marks what is being given. Don't write whatever you know, just in crisp. 10 marks, 8 hallmark, which means every hallmark carries 1 or 2 marks. Don't waste much time on it, fine. CDH1, it codes for E-cadherin loss. E-cadherin loss, at least remember one. We have the lobular carcinoma of breast. What's the other tumor which happens in stomach, which makes the stomach very thick? We have your diffuse gastric carcinoma, fine. Diffuse gastric cancer, the linitis plastica is also due to an E-cadherin loss, right? Perfect. VHL, at least don't forget this. We have clear cell RCC. Okay, we'll have multiple other tumors. We know that we have tumors of the retina, hemangiomas, cerebellar hemangioblastomas. We have splenic hemangiomas, lots of them, multiple hemangiomas, renal cell carcinoma, and also pheochromocytomas, right? Clear cell RCC, pheochromocytomas, which can happen in the adrenal, and lots of hemangiomas throughout the body, fine. One is required, must. Rest is for your distinction, honors, or gold medal, fine. APC, The syndrome is familial adenomatous polyposis. I'll have excess amount of, I'll have a minimum of 100 polyps in intestine, and obviously it will increase the risk of colonic adenocarcinoma. It goes without saying, when I have 100 polyps, colonic adenocarcinoma risk is definitely there. Again, if you want to add more marks, write about Gardner syndrome, write about Turcot variant, which are all variants of FAP. Fine. STK11, anyone, what tumor? The syndrome is Peutz-Jeghers syndrome, so it can increase the risk of Peutz-Jeghers polyp or Peutz-Jeghers tumor. And also, if it's cancer, don't forget this. I am okay if you miss adenocarcinoma of intestine in Peutz-Jeghers syndrome, but never miss pancreatic cancer, because the risk of pancreatic cancer is close to 50-60 times in patients with Peutz-Jeghers syndrome. Fine. Okay. So that's about few genes which is required, which is worth mentioning when you talk about tumor suppressor gene, right? Just again in a slide. This is more than enough for you in a long answer. Short answer also, this information is enough. Maybe write a little bit more word. Retinoblastoma, it's the governor of cell proliferation, blocks the G1 escape. When it's mutated, more activation. P53, it's a guardian angel of the genome. Make sure it corrects all the errors. If it is not there, I won't be able to correct errors. More mutations accumulate and goes badly. E-cadherin, the normal job is cell addition. When it's not, there's no loss of cell addition, causes your lobular carcinoma and diffuse gastric carcinoma. It's easily you'll be able to write. Leaf-Romney syndrome is a syndrome where there's a congenital loss of P53. Fine. Then altered cellular metabolism is your Warburg effect. Okay. Warburg effect, if it comes as a short note, write more about it. If it comes as an essay, just very limited things, what is required, just write them. That's more than enough, right? So when you have an altered cellular metabolism, the primary alteration here is nothing but all the glucose what is going there is going to get consumed by aerobic glycolysis only, and will be stopping of the mitochondrial respiration and diversifying all of them for your production of your nucleic acid. That's what it is, fine. So cancer cells, primarily what happens in cancer cells is there will be an altered glucose metabolism. That's what is Warburg's effect. So when I say altered glucose metabolism, it will be consumed only by aerobic glycolysis, right? It goes to aerobic glycolysis, it will stop at aerobic glycolysis, and the rest of them will be channelized to create DNA and RNA or nucleic acid. I'll just write to create nucleic acid by letting go of excess ATP production, right? In a normal cell, it will go into oxidative phosphorylation, produces ATP and free radicals, but in a cancer cell, it will not go into oxidative phosphorylation. That's a change which happens here. That's what is Warburg's effect. So I need more nucleic acid, and whenever there's more nucleic acid, there's definitely more growth. That's without saying there'll be more growth. Fine. That's Warburg's effect, right? So there are few things which is must in Warburg's effect. The gene which controls Warburg's effect. MYC gene is the master regulator of Warburg's effect. It regulates all the cellular metabolism which happens in Warburg's effect. So whenever I'm mentioning gene, it is mandatory for me to mention what happens when it's getting mutated, right? What is getting mutated? What mutation causes? One carbon pool is right, perfectly right. You can write Burkitt's lymphoma, right? And whenever I have a mutation of this, which will result in Burkitt's lymphoma, fine. Okay, I'm going to tell you what else to write if it's a 5 mark. See, if it's a part of a 10 mark, these 3-4 words is more than enough for me. Because if you write this entire process vertically, it will easily cover half a page. If it's a 5 mark question, 3 marks, 3 points is not enough for me. So then you write the 1 carbon pool metabolism. You write normal, it happens like this. Cancer, it happens like this in 2 steps. Then write MYC happens, Burkitt's happens. Write a word about tumor lysis syndrome also. But the most important thing is the applied aspect. Because of Warburg's effect, what was the investigation which happened? You can write that the investigation of PET scan. PET scan is based on Warburg's effect. Based on Warburg's effect, based on the energy utilization of your tumor cells, right? Good evening, Himanshu. Because the energy utilization of tumor cells, we inject FDG glucose based on the metabolism. We have the PET scan, fine. This is under molecular hallmarks. Obviously, yes, there are 8 molecular hallmarks totally. This is one of them, fine. Perfect. PET CT is one of the applications of Warburg. This requires if it's a 5 mark, otherwise just ignore it if it's a part of an essay question, right? Then evasion of apoptosis. It's very simple. Just give maybe one example for evasion of apoptosis, which is seen in follicular lymphoma, right? So what happens in a tumor cell is when they evade apoptosis, by default, there is going to be increase in cell division or increase in the cell's lifespan. Whenever there's an increase in cell's lifespan, by default, there'll be new mutations which will be accumulate. And when there's new mutation accumulating, by default, I'm going to end up and have a cancer, right? This is the reason why evasion of apoptosis can result in progression of a cancer. Example, you can have BCL2. BCL2 is pro-apoptotic or anti-apoptotic? Yes, FDG glucose. Pro-apoptotic, anti-apoptotic. BCL2 is anti-apoptotic. Everything with L, longer life, is anti-apoptotic. So if there's an overexpression of BCL2, which happens in case of translocation 14 and 18, in case of a follicular lymphoma, right? So that's an example. Follicular lymphoma, I'll have an overactivation which results in case of a cancer. That's an example for evasion of apoptosis. Fine. It's very simple. Again, this is very, very short. This might not generally come as a short answer. Maybe if university has 3 marks, it can come. It's not worthwhile to ask for a 5 marks, right? Then limitless replicative potential. The words you have to remember about limitless replicative potential is only one: the excess telomerase activity. That's something which is very, very important. So limitless replicative potential, any normal cell will follow Hayflick's limit and they will die. But in a cancer cell, when there is an overactivation of telomerase, there will be definitely increased telomerase activity. When there's increased telomerase activity, there is a reduced shortening of telomere. When there's reduced shortening of telomere, obviously what is going to happen? They're going to become immortal. So they become immortal, they automatically keep on dividing more and more and more. That results in cancer accumulation. And Vishal, we are doing it in different places because it's very difficult for us to find time to take in an entire shot. That's why we are doing like 10, 12 lectures on it. Please come sit in a single lot and have a look at them. Fine. Okay. So limitless replicative potential, and most of the time the telomerase activity increase is mostly an terminal event. Do mention this. Telomerase activity never happens as an initial event. Even if you remember adenoma carcinoma sequence of colonic cancer, it happens at last. Most of the time it happens a lot, be it breast cancer, be it colonic cancer. It's a terminal event in the cancer genesis. Fine. Angiogenesis is a very early event. One is terminal, one is a very, very early event in pathogenesis. That's one. Okay. The second thing, again, tumor angiogenesis happens due to in a very early stage, and it can be definitely blocked by drugs. By this time you must have known that we have an anti-VEGF. It can be easily blocked by all these drugs, bevacizumab. Fine. Okay. Hayflick's limit is the limit where every cell division will stop after some point of time, Samantha. So what happens in this tumor angiogenesis? There will be a more increase in the pro-angiogenic signals that favors the angiogenic pathway. So what are pro-angiogenic, anti-angiogenic? VEGF is definitely pro-angiogenic. Beta subunit of fibroblast growth factors pro-angiogenic. What are anti-angiogenic? Anyone? We have your angiostatin. Statin stops. Vasculostatin stops. Right? And we have thrombospondin. Fine. So all these are anti-angiogenic and they will stop the angiogenesis, right? So again, if it's a big answer, say that in a normal cell, in a normal resting cell, the pro and anti-angiogenic factor will be in the common place. But in case of a cancer, there'll be more amount of pro-angiogenic signal, which increases VEGF and sprouts out more new capillaries. And this happens in a very, very early stage. Even if it's like 2 millimeter size, to grow beyond that, I would require new angiogenesis. And if we know this early, we can use the drug bevacizumab, which is nothing but an anti-VEGF, which can be easily used to control the tumor growth. This is definitely one of the applied application of learning about angiogenesis. Fine. Okay. Then we'll talk about invasion and metastasis. Okay. Samantha, you asked about what do I mean by the steps of metastasis. This is what I mean by steps of metastasis. Both invasion and metastasis are hallmarks of cancer. Okay, they are hallmarks of cancer genesis. If I know it's invaded, definitely cancer. If I know it's spreading metastatic, it's definitely cancer, right? So what are the steps of metastasis? There are multiple steps involved in metastasis. draw in the form of a flow chart and write the important steps sideways, so it's much easier and neat for the examiner to understand, right? So if you want to draw a diagram, draw a diagram. So you have a big tumor here. The first step obviously is a basement membrane invasion. Then only I'm going to call it a cancer by default. After that, I'm going to have the first event, which is loss of E cadherin. So whenever loss of E cadherin happens, I'll get a single cell separation, which is ready to spread, right? Which can easily spread. So this next happens, the second step, I'm going to destroy the extracellular matrices, or you can write destroy the stroma. For destruction of stroma, I need enzymes, right? MMPs, perfect, right? So I'll have matrix metalloproteinases, which are actually produced by my macrophages. If you want, you can write them as well. M2 macrophages to be very specific, and that will destroy the stroma. Once the stroma is destroyed, the next step, I'm an epithelium. Epithelium cannot move. The third important thing is your EMT. EMT, you have epithelial mesenchymal transition. In epithelial mesenchymal transition, an epithelium turns to a mesenchyme with the help of two genes, with the help of twist and snail. They'll become mesenchyme, and this twist and snail, once it made mesenchyme, the cell slowly moves towards a target. It can slowly move towards either lymphatics or hematogenous, whichever the route is going, fine. So once I slowly move towards the thing, the next step is I have to destroy the basement membrane of the blood vessel or lymphatics, and then I become a tumor emboli. Tumor emboli, the most important thing is they are lined outside by WBCs. If you want, you can draw a diagram. Okay, these are tumor cells for me. I have a little bit of RBCs here outside. Then obviously I have WBCs outside. So when I have WBCs outside and platelets and RBCs outside, okay. Yes, Ravi Varman, the same thing. See, if you have listened to the original lecture, what I had told is this single cell destruction and destruction of ECM is actually an evidence of wound healing. Whenever wound healing happens, M2 macrophage comes, and M2 macrophage is the one which is going to heal the wound. The same way, wound healing will have remodeling. MMP is produced during remodeling. That's what happens in case of metastasis as well, fine. So tumor emboli, with the help of your chemokine receptors, okay, you'll have chemokine mediated exit. This chemokine will attract the WBC which is stuck on the surface. You can write that there's WBC that will respond to the chemokine, and you'll have distant organ, and in the distant organ it settles and it grows. Okay, this is what I mean by the steps of metastasis, right? If you want, put numbers 1, 2, 3 if required. Otherwise, a very long thing, I'm just doing it like a U, but draw straightly and sideways, right? What are responsible? Loss of E cadherin, what happens? Destruction of ECM, who does that? And I have EMT, who does that? Slowly it moves. If you want, add a word that movement is based on actin polymerization. That's how everything in my body moves, right? Actin polymerization goes into tumor emboli. What's a tumor emboli? What's the advantage? Next, chemokine mediated exit. How do they go? If you want to add one more word about chemokine mediated exit, most of the lymphatic metastasis, I have CD44, which helps in lymphatic metastasis, right? Then you go to distant organs. Every distant organ spread, there are few things which are common. Always every mets will be in the center or periphery. Every mets will be in the periphery of the organ, because everything here happens in the capillary level, so it will be the periphery. Every mets will be well defined or ill defined. It'll undoubtedly be well defined. That's why you must have definitely heard about cannonball secondaries in lung cancer metastasis. They are definitely well defined. They'll never be ill defined, right? And every mets you'll have a central necrosis. This can happen. We call it a central umbilication, right? So this clears entire thing. Again, when they ask a 5-mark question of metastasis, do you need to write this or not write this? I will leave to you based on the time. Because Mets 5-mark, if you write this, yes, I might definitely give you 4.5 or 5. If you just write the roots of metastasis, roots of spread, also is good enough. Based on the time available, shrink it and maybe at least mention about it. It makes your paper much more presentable. Fine. Okay. Samantha, as a part of 5-mark, yes, you might add. Otherwise, not required. Driver passengers for us to understand. That's all. Yes, yes, Devan can. Yeah, you are absolutely right. My only point of intention here is I need to know that outside will be WBCs. Tumor cells will have fibrin, tumor cells will have platelets, RBCs. On top of that, it will have WBCs because WBC is the one which will respond to chemogens. Fine. Okay. Okay, next. Mechanism of immune evasion of cancer can easily come as a 5 mark. There's a very high possibility it can come as a 5 mark because this is what the entire world is talking about. The immune checkpoint inhibitors, how a tumor escapes the cancer, and the way it is evolved as a part of treatment is very, very important for us, right? So this can come as a 5 mark and it's a part of the molecular hallmarks effort, right? So how does a tumor escape a cancer? The first mechanism is by altering the MHC molecule. Okay, that's the first one. Fine. If it's a 5 mark, write 2 steps. If it's a part of an essay, just write 1 step. If it's 5 mark, write normal. Every normal nucleated cell will have MHC1 molecule and which will be recognized as a self antigen. So I will not destroy them, right? Once I have an altered MHC, okay, some mutation happens, some virus enters the cell, then I have an altered MHC, virus or any mutation. This will be recognized by CD8 T cell, and CD8 T cell will kill the primary cell. That's what happens in a normal nucleated cell. Fine. No, it is not under the roof of metastasis. Fine. नवप्रीत, मेरा हिंदी थोड़ा अच्छा नहीं है इसलिए मैं अंग्रेजी से बोल सकता हूँ, ठीक है, और हिंदी में अच्छा फ्लो भी नहीं आते हैं. आई कैन लिटिल बिट डू दिस एंड दैट बट टॉकिंग टीचिंग थोड़ा प्रॉब्लम है नवनीत, राइट? इफ यू हैव एनी डाउट्स डू लेट मी नो, आई विल डेफिनेटली ट्राई टू हेल्प अबाउट इट. फाइन. So in case of a tumor cell, what happens is there will be no MHC molecule or there will be a loss of MHC molecule. Fine. So there's no MHC or there's a loss of MHC. So when there's a loss of MHC, it is not recognized by my CD8 T cells. Okay. When it's not recognized by CD8 T cell, then obviously a tumor cell will definitely escape the immune response. That's one, by altering the MHC molecule. That's one of the prime mechanism by which they escape, right? Second, I can have how to escape CD4, right? By CD4 mechanism escape is by altering the immune checkpoint. Fine. We have something called an immune checkpoint mechanism. Okay. So immune checkpoint activations is the way by which I can alter a CD4. Again, if it's a short note, write how does a normal cell work, how does CTLA4 PD1 works, then write about a tumor cell, right? So what happens in a normal cell is, or in a normal self antigen is, so whenever my antigen presenting cells expresses a self antigen, it happens only with the self antigen to a CD4 T cell. CD4 T will produce CTLA4 and PD1, which will block the response, blocks the activation of CD4, blocks the second signal, blocks the activation of CD4. This is what happens in a normal self antigen. So, but what happens is, in case of tumor, unfortunately, we don't know for what mechanism, but whenever an antigen presenting cell presents a tumor antigen to my CD4, they also produce CTLA4 and PD1. So they mimic a self antigen. When they mimic self antigen, obviously I will not be able to destroy them, right? These are the primary two mechanisms. Fine. Here, Samantha. This is CD4, Hooper is CD8. Okay. CD8 T cells. Fine. Okay. Fine. So this is the two important ways by which I can evade immunity, right? There are few more points in Robbins, which is very, very minuscule. If you want, add a note in that. Put a column 3 and say that tumor heterogeneity. Tumor heterogeneity is also by which I can escape immune mechanism. So what do you mean by tumor heterogeneity? Is a single tumor has multiple mutations. So if I destroy one escapes. It's like escaping of the virus by heterogeneity, right? My body produces a mutation, influenza mutates and goes away. You must have read that antigenic shift and drift in case of influenza. Same way, the tumor is very, very complex. Since it's complex, even if one part is being destroyed, the other part grows. It's very, very complex. I'll not be able to complete everything, right? Even if one part destroy, the other part grows and new mutation comes and it grows, right? Not very important, but CD4 and CD8 are very, very important. Whenever you write about immune checkpoint activation, you should not miss talking about immunotherapy. What are the drugs? Anyone? So immunotherapy is a new method of anti-cancer treatment where I give the drugs which blocks the CTLA4 PD1. I'm sure you know many drugs. We have anyone? Nivolumab, pembrolizumab, all the anti-PD1 and anti-PDL1 agonists, right? So immunotherapy, one of the important drugs is nivolumab. Nivolumab is anti-PD1, which will block the PD1 and make sure my immune cells can go and destroy the tumor, right? It's very successful in quite a few places, but it's definitely very, very expensive as well, right? So write all of them if it's a short note. If it's a long answer, just write what happens to a tumor. Just they don't have MHC1, so CD8 cannot identify them. If they have produced CTLA4 and PD1, so they mimic like a self-antigen. Tumor heterogeneity, so even one part is killed, other part escapes. And about immune checkpoint inhibitors, that's immunotherapy, and we have drugs which can stop them and help us to cure cancers. Fine, perfect. Now that's about the 8 molecular hallmarks of cancer, right? I've compressed it like anything. So use this as the final day. So you have to read something in the final day, because I'm 100% sure if I give you 1 point, all of you is capable of writing at least 3 lines. So if I have 10 points to remember, it's very, very simple for you to attend a 5 mark, even a 10 mark, right? That's the goal of this lecture. This lecture is not to understand concepts. It's just to summarize and cram up everything in the last moment, right? Let's come to paraneoplastic syndrome. Okay, perfect. So paraneoplastic syndrome, we know the definition. Symptom is different. Paraneoplastic syndrome is different. These are also signs and symptoms of cancer which cannot be explained by the anatomy or by the functioning of the tumor. Indigenous to the tumor which they arise from, right? So let's say I'm having a tumor which is arising from ovary. Can it secrete estrogen? Yes, no, maybe. Definitely it can secrete estrogen, right? So is that a symptom or paraneoplastic? It's undoubtedly a symptom. So I can explain that, right? I have a tumor in the pituitary. It can compress the optic chiasm. It's a symptom. That is not paraneoplastic, right? So if I'm not able to explain based on the, it's immune evasion. That's the other name of that, Samantha. Fine, yeah, you're right. If I'm not able to explain based on the anatomy or the hormones they elaborate, I call them a paraneoplastic. What are the uses? It can help in the diagnosis. Sometimes hypercalcemia will be the way by which your squamous cell carcinoma of lung can present with. There are many times your myasthenia gravis might be a way by which thymoma presents, right? There are many examples for identifying recurrence, for diagnosis, and to track recurrence. What do you mean by this is, so when you have a tumor, you can give an example. Let's assume you have an small cell carcinoma of lung. Can anyone tell me any one paraneoplastic syndrome small cell carcinoma of lung? Perfect, Cushing's. So the patient had Cushing's. Okay, so we treated the small cell carcinoma of lung. Treatment is successful. So obviously what will happen to Cushing? Will it disappear? Obviously, right? The symptoms related to Cushing's will obviously come down. It will disappear. All the things of Cushing's will disappear, right? SAIDH and Cushing's. So now, after a few years, let's say 2 years or 3 years, again, if you have a reappearance of Cushing's, what does it mean? If Cushing's reappear, my thing is there is a recurrence. The tumor has come back, maybe in the same place in the lung or somewhere else, right? Hey, Ravina. Okay, that's what we mean by tracking recurrence or tracking anything like a failure of treatment, anything. So it's normal and then it comes back. I know there's a recurrence. These are the 2 use case, right? 5 mark, this is more than enough. 1 mark for definition, 1 mark for use case. If you write this table, it's definitely worth 2 marks at least, right? These are common paraneoplastic syndrome. Robbins has a little bit more than this. If you're able to remember, great. Otherwise, just remember them. That's more than enough, right? Cushing syndrome. You already said one. Small cell carcinoma of lung. Okay. Here itself, right? Small cell lung cancer can also have SIADH. Syndrome of inappropriate ADH secretion and Cushing syndrome. They are classical things of small cell carcinoma of lung. Fine. See, once the treatment is over, Cushing's will go back. So if it comes back again, I think that the tumor has returned back. That's what I meant, Samantha. Fine. Okay. Okay. Cushing is undoubtedly most common endocrinopathy, which can be seen in case of a paraneoplastic syndrome, and this undoubtedly most common paraneoplastic syndrome. Hypercalcemia can be seen in squamous cell carcinoma of lung. Okay. Again, squamous cell lung cancer can also be seen in breast cancer. If you want, put one more table, one more column to write what causes them. Cushing syndrome is caused by, it's simple, it's caused by your ACTH like substances. Your hypercalcemia is caused by PTH-RP, PTH related peptide. I might not have answers for all of them, but some of them will definitely. Polycythemia, obviously, by increase in production of erythropoietin. Like ABCD said, renal cell carcinoma, cerebellar hemangioblastomas. Right? Both of them are actually linked with von Hippel-Lindau and your mutation of the von Hippel-Lindau. Fine. Okay. Acanthus nigricans, it's mostly an immunological phenomenon. Acanthus nigricans can be seen in case of an GI malignancy, internal GI malignancy, and also your uterine cancers. It is definitely seen in case of an metabolic problems of diabetes, but in terms of cancer, that is. Right? What is made Trossius phenomenon? Trossius sign or Trossius phenomenon is migrating thrombophlebitis. Right? What does it mean? I have lots and lots of migrating thrombophlebitis. It's seen in multiple places. The common denominator is mucin secretion. So if I have a pancreatic cancer, if I have a colon cancer, if I have a lung cancer which can secrete mucin, mucin activates factor 10. So when it activates factor 10 directly, there is an incidence of thrombosis. So can it also present as DIC? It can present as DIC as well, right? Same thing. It will activate factor 10 and which causes thrombosis. So most of the mucin secreting adenocarcinoma, when it's in excess, it can cause Trossier phenomenon. Fine. Red cell aplasia, as it can be seen in case of, and also your myasthenia gravis. Which tumor? Can be seen in case of thymoma, right? So thymoma can have both red cell aplasia and your myasthenia gravis. 5-6 paraneoplastic syndrome along with the definition and what is the use case is more than enough, fine. So that's in short about your paraneoplastic syndromes. Okay, I'm not taking tumor markers here. I have a lecture on tumor marker I shared with you guys in the Telegram and in the Instagram channel. Just have a look at that. There's some 10 minutes video. Tumor markers also same use case. The only difference in tumor marker is it's not a sign or symptom. It's a blood test which helps me to diagnose or helps me to track the recurrence in case of a cancer. And very classical tumor markers. You already know many tumor markers. Just compile them and add them as a short answer. There's a possibility tumor marker can also come as a short answer. Fine. Okay. Then let's go to carcinogens. Viruses or bacterial carcinogenesis or organism related microbial carcinogenesis can definitely come as a short answer. If worst case scenario, it can come as a long answer as well. If it's a long answer, it's fun. Think about each and everything and write. Because HPV itself, I am sure you can write for one page. You are capable of writing for one page, right? So it can be either oncogenic viruses or it could be a microbial carcinogenesis. It's definitely worth asking a 5 mark. Very rarely, if they don't want to ask the molecular hallmarks as a long answer, they might ask as a long answer as well. Fine. Okay. So now I need to have these 3 informations for every molecular genesis. If I have to compare in the form of a table, what is the organism? What problem in the organism is going to cause cancer? Fine. All the very best films, Telugu. I hope you will do well. What's your name? I'll wish best wishes on your name. White Films Telugu. Okay. So you have to know about what causes the cancer and also what cancer is going to cause. Fine. So HTLV1 is human T cell leukemia lymphoma virus. I have a gene called as TAT gene. The TAT gene is the one which is going to cause increased cell division, increased expression. Okay. Fine. Perfect. Tax gene. Yeah, tax gene. That. It's tax. Okay. Okay. All the best, Sai. Do well, prayers for you, and definitely you'll do well. Just be confident. You will ace the exam, right? Adult T cell leukemia, bar lymphoma. See, the beauty of expanding an answer is very easy. The thing to concise is very difficult, right? You can easily expand. If you talk about tax gene, adult T cell leukemia lymphoma, you can definitely know about the clover leaf shaped cells. You can put an image of that. You can write HPV, I'm sure you'll write a big story on cervical cancer all the way, right? So HPV, there are two things serotype, HPV 6 and 11, which causes benign conditions. The reason for benign condition is all the genome is in episomal form. They are not integrated. HPV, what are the serotypes it can cause malignancy? Anything which can cause malignant condition, I want you to tell the serotype. They are in integrated forms. Okay, they are definitely integrated into the human DNA. So once they are integrated, definitely there is a more risk of cancer. Perfect. 16 and 18 to start with, 31, 33, everything will cause, right? Squamous cell carcinoma of cervix. So HPV, like Sarkar said, I have two things, E6 and E7. E6 and E7 are the primary proteins, fine. So these are viral proteins, sorry, E6 and E7. Okay, these are the viral proteins. So E6 has two things, E7 has two things. E6 reduces P53, that's one. E7 reduces retinoblastoma. This is main. Like I said, there's one more activation as well. E6 will activate telomerase. The second one is optional, but the first one is mandatory. E7 again inhibits P21. It's one more cell cycle inhibitor, right? Ultimately, when this happens, obviously there's definitely more and more cell division, which causes cancer. Okay, write it perpendicularly. I'm writing horizontally because I put a table, that's all, right? So we have cervical carcinoma, we have anogenital cancers, okay, we have oropharyngeal laryngeal cancers that can also happen. Okay, of late, little bit of tumors of the stomach are also related to HPV, but its cervical is important. Anogenital is definitely important for us, right? Perfect, great. Next comes to Epstein-Barr virus. Epstein-Barr virus, we have two of them. One is called as an LMP1, that's a latent membrane protein 1, and the nucleic acid, EBNA. It's a nucleic acid of the virus, right? So Epstein-Barr virus enters into a B cell via your CD21 receptor or the CR2, right? So once it goes into the B cell receptor or the B cell, it will cause increased division of B cells. When there's an increased division of B cells, by default, there's an increased risk of lymphomas. That's how Epstein-Barr virus causes tumor. LMP1 and Epstein-Barr nucleic acid is EBNA, fine? Okay. So I'm just writing here B cell lymphomas. And once your WBC is done, you already know that. What B cell lymphoma in Hodgkin's, what variant of Hodgkin's, you can write that, right? You can write whatever lymphomas comes to you, Hodgkin's, non-Hodgkin's, anything, fine? At the same time, please don't forget nasopharyngeal carcinomas. If you've started reading ENT, this is one of the important thing which causes nasopharyngeal carcinomas, and also, as of now, it also results in gastric carcinomas as well, fine? One group of gastric carcinomas. Nasopharyngeal is important. LMP stands for latent membrane protein 1. Just write LMP1, that should be more than enough, Samantha. Okay, fine. It's important. Right, expand whatever lymphomas, Burkitt's can happen. You can have Hodgkin's, you can have multiple other non-Hodgkin's. In Hodgkin's also, mixed cellularity is more common. Lymphocyte depleted lymphocytes is more common. Nodulار sclerosis and your NLPCL will not be there, right? You can specify what is that based on the length of the exam and also the length of the time you get, right? HHV8, it's human caposiform virus 8. So it has a protein which is like cyclin D1. It has a protein called as cyclin D1 analog. So that increases the G1 to S phase transition, which causes increase in cell division. That's one of the common mechanism of HHV8. Three conditions in HHV8. Definitely you won't forget Kaposi sarcomas. That's one by default. Other two, we have one named one. What diagram, Samantha? Kaposi is one. The other one is Castleman disease. Okay. So Castleman disease also is one more, right? And then we have primary effusion lymphomas. So these are three things which can happen. Okay, fine. The surname is not there, so I got confused. Okay, effusion lymphomas. Okay, Hetty. Okay, thank you for the Telangan. Fine. Fine. Now let's go to HBV and HCV. HBV, HCV, I don't have any particular problems. Okay, HBV and HCV is more of inflammation related. Please tell me, Hattie or Samantha, whatever it is, what diagram, I'll definitely try to explain that, fine. It's more of inflammation related cancers. Whenever there's more inflammation, by default there'll be more reactive oxygen species. Reactive oxygen species will cause mutation, which definitely causes cancer. Fine. So that's how HBV and HCV will cause cancer. And obviously there's only one denominator here. Hepatocellular carcinoma is the denominator, right? Can anyone tell me what are the genes or what are the problems with H. pylori? H. pylori has CAG-A and VAC-A gene. Both of them are more pro-inflammatory. Once they are more pro-inflammatory, the same problem. It will cause repeated inflammation, more mutation and cancer. Okay. So H. pylori has very interesting things. Perfect. Maltoma is one, right? Gastric carcinoma is a straightforward thing. I want you to write that there's an increased risk of gastric carcinoma. Okay. There will definitely be an increased risk of maltoma. Can anyone tell me what will happen to the risk of esophageal carcinoma? Protective or it will increase the risk? Please do write that as well. It will be protective to esophageal carcinoma. Okay, so that's what happens. It will be protective to esophageal carcinoma and it will be increase the risk of your gastric cancer. The reason why it's protective is H. pylori causes atrophic gastritis. Atrophic gastritis reduces the acid secretion. Acid secretion reduces the GERD. GERD reduces the Barrett's esophagus, reduces the esophageal adenocarcinoma. Fine. Ashad, that question does not make sense, right? So when I say most common, it's based on the incidence of RCC or HCC, right? Both of them can go via hepatocellular lesion. Both of them can go via hematogenous route. Every cancer can go via hematogenous route, right? If it's you are asking from the premise of an MCQ, whatever you read, please share me the MCQ. I'll be able to help you with that, right? But as on a superficial note, that question does not make much sense. It's based on the instance of HCC and RCC. I can say which is more common, fine? Okay. Schistosomiasis and clonosis, both of them are again inflammation related. Okay. After microbiology, you must have known many more things about these organisms than me, right? I'm 100% sure that Dr. Mamta must have made that happen, right? When there's more inflammation related, same thing. I'll have more mutation, I'll have more cancers, right? No menstruating men, it's exams. Exam is different, concepts and learning are totally different, right? Schistosomiasis, what cancer? You'll have increased risk of CA bladder, right? CA bladder, squamous cell carcinoma of the bladder can happen, or the translucent cell carcinoma can happen, fine. Samantha, it's because of reduced acid secretion, right? It's atrophic gastritis. No gastric cell, no parietal cell, no acid, so less Barrett's, protective against esophageal. It will cause gastric cancer, but it will protect esophageal cancer, fine. And clonosis sinuses, and there's one more thing, you must have read this, fasciola hepatica. These two of them goes and irritates the gallbladder epithelium or the biliary epithelium, which can cause cholangiocarcinoma. Okay, it can cause cholangiocarcinoma. That's what it can happen in case of clonosis sinuses. Fine. Okay, that's in short with whatever we see for C. Maybe you can remember that it's gallbladder epithelium or the biliary epithelium. Fine. Okay. In short, about most of the things which we need to read about cancers. Fine. Difference between benign and malignant, which is there in Farre tables, whatever is there in Farre, take some time to learn, take some time to write also, fine. If there's a question on difference between benign and malignant, don't just start writing. You will end up in 4-5 options, that's all. Think about a benign tumor, think about a malignant tumor, you can easily write the difference. Dysplasia, divide them into gross, symptom, malignancy, sorry, microscopy, IHC if you want, right? So that you can easily structure a question, right? Okay. Neoplasia might be difficult to learn, but once you know neoplasia, it's very, very simple to recollect them because it's 1 + 1 = 2. It's very simple like that, fine. Okay, ABCD. You can ping me on this number 7760157195. If I don't reply, put a question mark and ping me again. I'll definitely try to reply. Okay. ABCD, I'll be concentrating on hypersensitive reactions tomorrow. That's one of the important thing in case of immunology. Though you must have had much more knowledge of immunology in your microbiology. Do you want me to talk about hypersensitivity or ignore? Because I'm sure that overlaps between micro and path. Something which does not overlap between micro and path is graft rejection, amyloidosis, which will not overlap, autoimmunity, right? Samantha, I'll definitely do platelet and your cardiomyopathy. Maybe I'll do something on the Sunday afternoon. I'll definitely take about that. Fine. That's good, Raitisha. Be happy. Fine. Okay. I'll talk about graft rejection. I'll talk about amyloid. I'll talk about a template of autoimmunity and genetics. I'll talk about chromosomal disorders because this is the one which is there in your CBME. Rest of genetics is not there in your CBME. Fine. Okay. Fine, guys. Thank you. Thank you for your patient listening and patient time. All the very best. If you have exam early, be happy. You'll do very well. All the best for you. Don't panic. Fine. It's more than enough, Rahul. See, once the exam is over, no, you'll feel that it's really, really more than enough. Fine. Okay. Great. Thank you, guys. Good night. Thank you for your time. Bye bye.